Hi, everybody, and welcome to Greenspace's first live in-person event. We're live from Homewood Health at the Lecter Theatre in Guelph, Ontario. My name's Jeremy Weisz. I'm the co-founder and CEO of Greenspace Health, and I'm honored and excited to be here today with Shannon Remers, the Director of Research and Outcomes at Homewood Health. Before we get started, I want to thank you, Shannon, for taking the time to be here with us today and to share your and Homewood's measurement-based care journey and the impact that it's had to date. I'd also like to thank everybody who's joined us today for taking the time to learn about the impact that measurement-based care can have. So before we get started, a little bit of an introduction and context setting. A lot of the attendees here today are people that know us well at Greenspace. Clinical leaders, partner clinics and organizations that we work with, but many are new to Greenspace as well. So as a quick introduction for those who are new to Greenspace and a little less familiar with us, we're a mental health technology company focused on helping clinics, hospitals, and health systems implement measurement-based care across their services to better understand the impact of those services and continually improve the overall quality of their care. Greenspace was founded about 7 years ago out of a major research hospital focused on bridging the gap between research and the clinical setting to bring the impact of measurement-based care into day-to-day practice for clinicians and organizations. While the research was compelling, it just wouldn't see widespread implementation without making the process much more simple and automated for clinical leaders and clinicians. And that's ultimately where Greenspace came in. And we set out on a journey to build the technology necessary to make the implementation of measurement-based care easy, to reduce barriers to implementation, and provide clinical value to both clinicians and their clients. Fast forward to 2024, we now work with over 500 organizations across North America that are implementing measurement-based care across a wide variety of programs and populations. We started working with Homewood Health in 2018, starting with a handful of clinicians in their depression care and trauma care programs. And fast forward now 5.5 years, measurement-based care is now being implemented across 20 different programs with over 10,000 clients. And so as I mentioned, I'm joined here today by Shannon Remers, who is the Director of Research and Outcomes at Homewood Health. Shannon leads Homewood's internal research initiatives aimed at optimizing outcomes, bringing best practice into programs, implementing measurement-based care and treatment, and using psychometrics to help determine optimal treatment plans. For the last 10 years, Shannon has led the development and implementation of measurement-based care at Homewood and continues to look for ways to maximize the use, benefits, and clinical applications within Homewood, as well as the larger mental health and substance use system. Shannon has worked in the mental health and addiction sector for 15 years. She received her Master's of Science in Cognitive Neuroscience from Wilfrid Laurier University and a Bachelor of Science in Biology and Psychology and Diploma in Forensic Science from St. Mary's University. So thank you, Shannon, for being here.
Thank you.
It's always a pleasure to work with you, and I'm really excited for this session. I know you're going to provide a lot of valuable insight to both clinical leaders and clinicians who are in attendance today. And all that said, I'll pass it to you for a few opening remarks.
Thank you. Thank you for having me. I'm excited about sharing what we've been doing here at Homewood. I'm excited to talk about measurement-based care and the impact it's been able to have for our clients and individuals we serve, as well as for an organization and understanding what the population needs are and how we can really make improvements to the system overall.
Great. A couple housekeeping items before we get started here. So first off, we're going to have a Q&A style discussion with Shannon today. And we've dedicated time for questions at the end. So if you have questions, and we encourage you to ask whatever might be on your mind, please use the Q&A function in the webinar. That's our preference over the chat. It's much easier to see the questions that are coming in. And we'll be sure to respond to as many of those questions as possible. We'll also be using the upvoting feature. So if you see a question that you like on the Q&A, and that's interesting to you, just click upvote, and we'll answer the questions based on the ones that have been upvoted the most. So we can prioritize those ones. And then at the end, if you're able to fill out the survey at the end of the webinar to help inform future events and sessions that we offer, that would be very much appreciated and will only take a minute or two. So with all that housekeeping out of the way, we're excited to get started. And I'll start it with the first question to Shannon. Maybe just to tell us a little bit about yourself and your journey into mental health services and to Homewood Health.
As I was finishing my graduate school and studies, I was really looking to get into a role where I could learn and utilize the education I had in psychology and that background to benefit the people overall and people's well-being. And I actually came across this job shortly after, about 9 months after I had graduated, to start as an outcomes coordinator here at Homewood. And it seemed like a really good fit to kind of have that indirect but direct care linkage. And then it was really shortly into that journey that I realized that using the measures and the data to really inform practice and understand who we're serving, who's, being helped by the services we're receiving, but maybe also who is falling through the gaps, we could really do a lot to help improve the system overall, improve our services at Homewood. So I have been with Homewood, as you mentioned, almost 15 years. And it's really been this escalation and journey as we've been able to maximize and build on using measures to really underlay or give the foundation to the services we're doing here.
So I think what's interesting to me for this conversation is the fact that you have been here 15 years. You've really seen the evolution, not just in the way that Homewood delivers services, but also how data outcomes and measure-based care is thought about across the organization and how it's evolved. So maybe tell us a little bit around how Homewood originally started thinking about measurement-based care, and then why the decision was made to implement it as a core part of the services that are being offered.
So at Homewood, and I think in the mental health and substance use sector as a whole, everybody's in this field to really provide benefits to the individuals that need the service. We want everyone's well-being and quality of life to be improved by whatever point in the system they're interacting or contacting. So for Homewood, we're always looking at ways to improve our services. We really function on a quality improvement foundation and working system. And we really quickly in our journey realized that there's a lack of knowledge and understanding of even who we're serving, and how people are doing, what that population looks like, what trends and impacts are changing that over time. And once we were able to have some measurement in small ways in the system, we were able to start to see, okay, we now know this about this group of patients or clients or individuals. Or we didn't know this, and people now are asking these questions like, is there an increase in depression severity or anxiety severity after event X or Y? And we were here during, I was working here during 2008 when there was an economic crisis, and then again during COVID. And you could see even those as more global or larger scale impacts environmentally, the impacts that it had on individuals and the people we were serving. And we were able to dive into kind of our health learning system, as we call it now, kind of the measurement-based care data to understand what are those differences, how can we support them, and how can we serve. So we're always looking to understand how that quality improvement and bring in best practices as well. Mm-hmm. And so during this past 15 years as well, there wasn't much talk of measurement-based care 15 years ago. And that has continued to escalate, and more research is coming out, and it's really undeniable now that measurement-based care has direct benefits in and of itself. And so that is also a major reason why Homewood here wanted to bring that into practice in a formal way.
So it sounded like it was something that was sort of started from the internal drive from within Homewood to say, look, this is an area that we want to pay attention to because there is a gap in terms of information and knowledge. And did that come from the leadership level? Did it come from clinicians first? Where did it start?
I think it started probably at the clinician level, but at the leadership level as well. We were starting to look at data. How can we use data to support decision making and all of those things? And it really quickly, whether it was from leadership, where they maybe were looking at business data to start, quickly realizing clinical data and those pieces were fundamentally important to decision making. But then clinicians also needing and asking for more information to really be able to understand their clients as well. So I think it kind of escalated on its own, and I think we'll get into it a little bit more of even how that led throughout the journey of Homewood and where we are today.
That's great. So let's talk about implementation. a little bit.
Mm-hmm.
So tell us about what the implementation journey looked like. Was there an implementation strategy? Did you start with a specific program or subset of clinicians first?
It really has been a journey over multiple years. We're not going quite back to when I started on this slide. But in 2014 and then in 15, we officially kind of launched what would be our first strategic project to really, implement and test out the feasibility and effectiveness of a measurement-based care within a single program. So we scaled down, thought about a pilot program. What could this look like? And for us at that time, to make it impactful and have some understanding, we had it start as a research project, which many people have started their journey in the data collection realm of it, whether it was research or data collection, but maybe not integrated it in their clinical practices. But this was a full research project led by our research team. We have a separate Homewood Research Institute, so that group was involved. Myself and a few others were involved also from a clinical standpoint, and that involved really one program in our addiction medicine services where patients were invited to provide consent, sign up, participate in this project. They were asked screening tools at admission and discharge, as well as then during their follow-up for up to a year. And that let us just get some foundation in there. What would this look like to start collecting data? It started paper-based. There was scoring, but we were able to provide summaries of those reports and the scores back to the clinical teams once we moved it out of research. So when it was research for research, it was collected in that way, and we could understand and learn for knowledge translation and learnings. And that really also helped catalyst that this was and could be a very powerful tool for Homewood, which then led to more buy-in, more strategic support, the leadership engaging, etc. And so that moved us to where the data collected while patients were in the program, still in one program, being part of our clinical processes, just our general internal processes, because we also realized very quickly, we were asking the clients that we were serving to answer things clinically and then participate in a research project where they were often providing similar information. So that inpatient part, we moved towards collecting all inpatient, which then allowed us to still have support from the research team, and we were then able to give that information back to the clinicians right away. So that was really the first step, and it was about a year afterwards where we could start using it more in kind of a measurement-based care way and not just a data collection system. The follow-up part of that still remained as a research project. And then it's really been iterative since then. So there's been movement to electronic data systems. So this first move was our first example of moving to electronic data systems. And then there's been a few different systems in the background. And then in 2017, and then we launched in 2018, we partnered with Greenspace to use that system currently. Current date, now we have all of our inpatient programs, voluntary programs using our touchpoint system, which is what we call our measurement-based care program at Homewood. We have our different inpatient facilities using it. So we have Ravensview out in BC and Homewood Health Center and Homewood residents, as well as our outpatient services are also using this. So we've really been able to expand our learnings and bring that across all of our services. And we're really at a spot now that we're finalizing some integrations with our EMRs and such so that the data is readily available to all clinical folks that could use or access or benefit from this data, as well as improving our feedback loops so that clients are engaging and seeing all the information and really maximizing that benefit, as well as making sure the clinicians are having those conversations. And now it's really let us have, a multi-year system of kind of what we're calling the health learning system of data to really understand the populations we're serving, how they might look in an outpatient setting or an inpatient setting, or even across programs. And it's been really powerful to support some decision-making and program improvements that we've done over the last few years.
Interesting. One of the things that stood out that you said was, while it started as a research project, pretty soon after, you were making sure that you were getting the summary information back to the clinicians. One of the things that we often hear from organizations who have dipped a toe in the water around measurement-based care is we are measuring outcomes, we are capturing data, and we'll get into this a bit more in the next question, but we're not getting buy-in. But oftentimes it's because the data is being captured, but it's not actually making its way back to the clinician. And it sounds like in your scenario, by bringing the information back to the clinician, in addition to supporting the research study, it also generated more buy-in from the clinicians to be able to see the clinical utility. And so would it be fair to say that you're, looking back, looking at the journey, it was almost organic in nature to some degree, where you showed value from measurement-based care, and then it allowed you to add more programs and services rather than saying top down, hey, we're going to do this, trust us, it'll work.
Yeah, 100%. So it allowed us we started in pilot. It seemed kind of contained, one program, see how it goes. But very quickly we could see how that would benefit more globally. But also we had the example, and we had local champions, a much larger group from those programs. And then we also have flexibility in how clinicians might move within programs and such here. And so some of the clinicians that maybe moved from this pilot program into a program where we weren't using that system, that really led into conversations in the front line. Like, we used to be able to access this. How can we access that? And really brought kind of that forward. But I think for sure it was kind of an organic. And then as we were also then able to demonstrate the benefits of all of this, the strategic direction from leadership was present as well.
You guys have obviously had a very successful implementation over the last number of years. And we know that one of the key components to being successful with measurement-based care is getting clinician and client buy-in. I also, in the Q&A, I'm not supposed to look just yet, but there's a lot of questions around how do you get engagement and buy-in. So can you describe what some of the strategies that Homewood has used to ensure that you've been able to get clinician and client buy-in?
Yeah, so that is definitely a big milestone to meet, and it can be challenging, but it also can be overcome. So I think it's not surprising that we're getting those questions, and it likely will be a challenge within your organization, but you can also overcome it. So I mean, a big one for us was really having the early stage information that we could make available and not necessarily require clinical time to begin with, right? So it wasn't like, please do this in addition to everything else you're doing on the side of your desk. But what if we can bring you information that can help make some of your clinical roles and decisions easier and more efficient? And then they were able to feel that benefit right away when they would go back and start the conversations or review with clients. And sometimes it could be reviewed just within the clinical teams as well, right? If there's a more difficult case or something more challenging or unusual, this is another source of information that they've been able to now learn. Oh, wait, we have access to this. Oh, wait, we're struggling here. What if we go back to the touchpoint system and see, is there more information? So it's really kind of been an organic but intentional presence of trying to figure out how do we make this most available. We also have made data available in many different ways throughout this journey. So like, we started with paper and pencil, so that looked like a paper and pencil feedback system. We've made different versions of PDFs. We've made tip sheets or summaries. We have electronic means in which we can give the feedback now as well, but some individuals still prefer to have their own kind of tip sheet where they bring the numbers as they meet with their clients at each different time point. So we have also set it up in a way that we have key milestones or markers that as we've rolled to each program, we need to have, but also allowing and having those conversations with each of the programs as we're ready to roll out with them, and then continue those conversations of like, we need to do the step A, whether that's run an assessment group or have the individuals complete them on their own or have it done one-on-one. They have to do it. What do you think is going to work best for you and your team? Mm-hmm. So that was another way to really build though in the buy-in, like letting them be part of the decisions that they could be part of. And then and a lot of trial and error, like, let's try doing it this way. Oh, nope, that didn't work. Let's flip that quickly. Or actually that's working really well. Let's bring that. This other group might be struggling a little bit more. How do we support that? And as we built on the momentum that we were and the engagement we were getting, then we also were able to bring frontline clinicians and otherwise to each other's groups and programs to bring their own experience in that level of conversation. So it wasn't just this external body or person outside of the team saying, we're doing this. We were able to really integrate it at all the levels of conversation and in all of our levels of care. So frontline, management, senior leadership, and strategic. It's been a really integrated part where we needed all the levels involved.
That's great. There's a couple of things you said there that I want to just touch on. that I thought were really good. You made the comment around when presenting it to clinicians, instead of positioning it as, here's this other thing you have to do, positioning it as, here's something that we're doing where we're going to be able to bring you this additional information. So it's very much framed as like a benefit to clinicians that they didn't have before, rather than, hey, here's this other thing that you have to do, and there's benefits of automation that make it so that it's not some other thing that they have to do. The other piece that I thought was really interesting was your comment around trial and error. I think that it's easy to say that, and I can say this having worked with you guys at Homewood for a while, there has to be a mindset around trial and error, and communicating that to clinicians as well, which is saying, look, we're getting started. This is our best estimate on what the best process or workflow looks like. But if it's not the right process, that's okay. Let's try something different. Let's look at doing it a different way. And it sort of creates a space for clinicians to speak up and say, hey, what if we tried it this way? That could be more effective. So I really like that one. But I'm not going to let you off the hook on this question yet, because I want to talk about client buy-in. So you talked quite a bit about clinician buy-in. What have you seen from clinicians to engage their clients in the process?
So we had some clients who right away, they're engaged already. This is equally as interesting to them to answer the questions, have some introspection on what they're asking. What does that mean? Seeing their results. I mean, clients weren't always able to see their results, but as that was available, that was great. And then you have some clients who, right away were like, why am I answering more? Like, I've told you this, I don't want to do it. And then you have the middle of the road. But as we were able to provide the information back through the clinicians, we've even tested and trialed this by having, a person that wasn't part of the program having those conversations, but they're already interacting with groups of clinicians or an individual clinician on a regular basis. That was definitely the way that they felt more integrated. And so clinicians would bring back some of the information or be like, I know you completed your measures this week. Like, let's quickly, did anything stick out to you? Let's quickly look at this. And right away, then clients were like, oh, that's why you asked us to do this. That's why. And then they were more engaged and even asking often, when do I do them again? Or when their assessment group came up again. Right now, for context, we ask at kind of the beginning of treatment, which could be an inpatient stay or an outpatient, and then at one progress if they're inpatient, and then a discharge, or at kind of a monthly-ish interval in an outpatient world. So they'll ask, what about this? And we've even had a few clients who look at the results on their own and are engaged enough that they're like, could I do a couple of the questions more frequently because it's helping me understand where I am. We also, I'll just tie in just one really good kind of story that I was directly involved in. I was actively in a group on one of our inpatient programs here in Guelph, and we were running, I was supporting a new therapist and understanding and how to use it. We had, I think, about 6 patients in the group. And one of them was coming back to do their progress. And you could just tell they weren't engaged. They were like, this felt like a chore to them. Why am I doing it? I later learned that there was some struggles and they were debating and contemplating and had brought it up that they might leave the program early. So I was able to just flip open and look at their results as soon as they were done. They stayed in the room. I was like, do you want to just wait? Let's look and see. And we realized that their cravings had stayed and actually, in fact, increased over about 2.5 weeks. Their mood and anxiety had started to decrease actually a little bit, but it was this craving. And then you could understand why you might feel slightly agitated and not comfortable. But we were able to bring that back to the nursing team and the doctor right away and have things adjusted to support that patient. When I saw them at discharge, they told me that was a pivotal moment, and they stayed in the program for that reason. And then they were able to get the gains of the program before they left.
That's a great story. I like that one. Yeah, the piece that you mentioned that we see, we have seen in many other settings be really successful, more than any script that clinicians are using to pitch the client or any automation or functionality, is the fact that the information the client has provided in one of those assessments is brought into the session, because it clicks for the client. It says, oh, that's why I was asked to complete that assessment. And so the next time they're prompted, whether it's in session, whether it's in the waiting area, whether it's remotely, it clicks as, oh, if I complete this, this is going to be the basis of what we talk about. And so that's the clearest connection from our perspective.
Yeah, I'll just add to that really quickly. One key part of what you were just getting at there is also that something that can be a barrier for your staff is that how am I supposed to review all of these measures? And even at Homewood, depending on where you are in the service that you're having, it could be a lot of measures or it could be a couple of measures. And that also doesn't have to be, what do I do with all of these? What if you pick a couple to have in the conversation? It's going to feel overwhelming the first time you do it as a clinician. It's going to feel probably overwhelming to look at it all from a client's perspective. So what if you, I don't know, ask 5 or 10 questionnaires? What if you just talk about 1 or 2? Have it for like a 2 to 5 minute start of an interaction or conversation and then keep it going. It doesn't have to be this grandiose conversation that takes a full another hour of time each week with each patient and all of these things. It just has to become integrated in your daily practices. And that is a piece that I really am excited about because I feel like over the last year and a half or so, I can see how it's really moving into an integration and not this extra still kind of additional part of the program.
That's great. Let's transition from implementations to outcomes a little bit here. So what are some of the key outcomes that you and your team have observed through the implementation of measurement-based care? And how has that transparent and strong outcome data helped improve programs?
Okay, so I'm going to kind of focus on the overall observations first. And so just recently, I mean, it's come up a few different times, but more recently, and even I think in Dr. Clark's series, there was talk of benchmarks and understanding what is the level of improvement that we should see. What should we expect based off this level of care? And that in and of itself is a really good conversation to have. We haven't had data systems or health learning systems like these before to even have existing benchmarks. So when we go back and say X amount of people improved in this program, is that good? Is that bad? How do we know? But we also have to start talking about it to get the conversation going. And as we all start to use this data and this infrastructure, then we will start to have benchmarks and we might be able to move to a spot that we can understand what overall in the system is working, what works better for what groups of patients and or in clients. So we're at early stages of really that, understanding how has this looked over time or how does this look against general benchmarks and otherwise. So I would say we're pretty early, but it's a big topic that we want to really dive into more. But on some of our earlier programs that we've started in, you can see the level of engagement and the level of improvement and the level of therapeutic alliance really either staying strong or gradually improving over time, because it's also the more you use it and the more it's integrated into the program, the better the engagement and the outcomes and the connections will be. So that's what I'll kind of say with the overall trends. But we do use, and we have used this information quite a bit to really understand our programs, understand the individuals we're serving and what's working and what's not working. And so this is just an example of some data from our addiction medicine program where we were looking at and trying to understand how are people doing it and what are their presentations and are there different subgroups or cohorts of patients coming through here that maybe are, falling through gaps or not maximizing their results. And what we were able to see is that there was a cohort of patients who had higher anxiety levels and higher depression levels than another cohort or half of the group. And that actually led to a whole redevelopment and a new program stream that increased the length of the program and involved an integrated concurrent treatment STEM within, or stream, I should say, within the program. And we were able to, use this data amongst other information. So just like anything else, this data doesn't take away all of the other clinical information we have and clinical interviewing and all of those things. It also doesn't take away all of your other information that you'd have from data support. It's just another layer of information we have. But we were able to really understand and bring that back to our senior leaderships and executive to say, we're missing the mark here, and I think there's a big opportunity. We had a wait list before we even finished that sentence for this program because there was this gap of service. But so we were able to basically understand the data, understand there was a gap. We launched this. We did early pilot and a first year of data and review. This is just showing their presentation at admission, but you can see based off the concurrent program and the substance use only program that there's different levels of presentation in their anxiety and depression symptoms. And then we were able to then treat them accordingly to meet the needs. And our early pilots have had really good outcomes, really good feedback from referral sources, and we've been able to use that model now in other program changes that we've been doing.
What are some of the most important learnings that you and your team have taken from your measurement-based care implementation over the years? Maybe putting on your hat, looking at it from the perspective of some organizations who maybe are earlier in their journey or thinking about whether to adopt measurement-based care. What are some of the key things that you'd share?
So I think my biggest one is just start somewhere. Going back to the conversation that you brought up as well, we have to be able to move to that kind of trial and error mindset. Not everything that doesn't work is a failure. It means that it's a learning opportunity to understand what might work better. And so it doesn't have to be perfect. Where we are is not perfect. There's lots of room for improvement still, but it's been a multi-year journey, as you saw earlier. So anything is better than nothing. If you have a little bit more information to guide your decisions, both clinically and from a business perspective, how can that be bad? And then you can just start to understand what else you actually need to know, what else is beneficial. But really making the most of partnerships was a big one. And I mean that across the board from we needed our IT teams involved. We now have HR has descriptions in many of our clinical job roles about measurement-based care and having that understanding. But we obviously needed the clinicians and the early adoption from the clinical folks and the frontline folks. Let them be part of the conversation. There might be there's going to be steps in the journey that you have to have. But if there's room for them to say, what if we tried it like this? Or what about this? Let them be part of those conversations and have that. We've optimized our technology and our tools. I mean, that's been an ever-going journey as well. Even looking at the tools themselves, we were able to quickly understand in one of our eating disorders programs that there was a large cohort of patients that also had substance use based off the measures we were adding. But we didn't originally have the substance use measure in that program. So we didn't realize we knew that it was probably present to some degree, but we didn't realize how prevalent it was in that program until we added in the measure to really understand that. And really going back to that change management style, this is an overall foundational clinical practice that can have profound impacts. But just like anything else, change management can be difficult in a small system or a small organization, and it can be hard, but you need to look for those early adopters. You need to maximize and take on that momentum with your champions, be able to provide actually the benefits back in, which helps build that, and eventually you will move people through that decision making. And you might still have a couple of people that don't ever get on board, but maybe that answers some other questions for you as well. And also don't reinvent the wheel. Like other areas and programs and organizations are happy to help and have these conversations. There's teams looking at what does this look like? What could a progress outcome monitoring system or a measurement-based care system, there's lots of words for this. But what could that look like? What could that look like? What would be a standard a standard package of practices and how you could implement? There's projects and teams of people involved working on things like that right now. So don't feel like you have to go at this alone. And then ongoing work, we're trying to really implement and understand post-discharge as well. So that's been a lesson learned. I wouldn't say we've found our groove in that quite yet, but I think we're making strides there too. So again, it doesn't have to be everything all at once. And even during the iterations, that might, some things that were working really well in an earlier phase, when you switch, you might get benefits here, but maybe not here. And so then you just keep trying to figure out what works all together as you're moving through this journey. But having leadership buy-in and your internal champions were huge, but I would go with just start somewhere.
I like that one quite a lot. One of the common discussions we'll have with organizations who are starting implementation or considering implementation is around the assessments that may be used and the frequency that those assessments might be used. And there's often a lot of loud voices in the room that says, I believe there should be these assessments or these assessments. And we're often asked at Greenspace, well, do you have any recommendations? And we're absolutely happy to give recommendations, but the most important one we give is just start, because you won't know how particular measures are received by a certain client population until you try. And it's okay to make adjustments. It's okay to change. So I agree with that one wholeheartedly. It looks like we have time for one more question maybe, and then we've got lots of Q&A to answer. You've well articulated today, the success of Homewood's measurement-based care implementation, the positive impact it has had on clients. What's next for Homewood with respect to measurement-based care? And feel free to touch on, can be expansion plans, different uses of the data, research, how you're going to use it from a business perspective. Would love to hear how you guys are thinking about it.
I think from a clinical perspective, we really want to fully integrate with our EMRs. So we have right now key clinician groups, and it will probably stay that way for the conversations with clients and everything, but there are pieces of our measures that impact clinical folks that maybe aren't having that same level of interaction with the patients on a regular basis. And so if we can have all of the information also in their EMR, then anyone supporting the individual can see their information and have access to that. So that's where we are from kind of that key clinical and continuous support for how do clinicians really have those conversations, how do they feel supported, making sure onboarding is properly done, that this is a key part of that. I think we'll continue to use and maximize the information to really drive decision making for what is the next, what does a new program or an improved program need to look like? What do the individuals who are coming through an outpatient program or an inpatient program look like? Are there trends? Are there differences? Are we meeting those needs? And if we're not, so we want to continuously look at that and make sure we're meeting those. And then we also have a current research project underway actually right now to evaluate our implementation to date with this most current version. So that some of the findings from there we're really hoping will help actually drive some kind of basis for a starting point of some standardization on how could you start? What would that need? So that we can provide information back in knowledge translation ways just like this, so that we can really help, the whole system move in a better direction and have access to this type of information if it is helpful for them.
That's very helpful. From an organizational perspective, we talked a lot about clinical today. Mm-hmm. And looking forward, has there been any thought or discussion around how the quality of outcomes that Homewood's been able to drive and is very clearly able to articulate, if and when and how that can be used at the organization level, whether that's communicating with new organizations that you're partnering with or commercial opportunities?
Yeah, so we do use and reference this system with certain, contracts and partnerships as we're kind of underway and having those conversations. So it's definitely used to articulate what can Homewood do, but also how do we do it? And this is, the rigor and stuff behind it. And then I think that we do want to look into how do we maximize the use of this information. So one thing I hadn't really touched on here is now we have this up and going, it's implemented, it's integrated in the clinical care, but really this is like a large data system that has required, a new kind of layer of data management that we didn't previously have, and I'm sure many organizations and even the system might not really exist. So we really wanted to prioritize the privacy and security and all of those pieces around all of those. So as we have that now built and accessible, I think we'll now just have a whole nother data system where, again, a health learning system that we can really learn from organizationally, but hopefully also help improve the overall system in Canada too.
So really being able to take the data that you have collected and continue and feed it back into the start of the treatment journey for each new person so that you're continually getting better.
Right.
That's great.
Yeah.
So we've got lots of Q&A from the audience, so thank you. Like we said at the start, we'll prioritize based on those that have been upvoted, but lots of time still to add questions and to upvote. But why don't we start with, we'll start with the one right at the top of the list. So for Shannon, can you give us a couple examples of data you're collecting besides the assessment measures data and how it's used?
So some of the data, so we have domains around symptoms, which I'm wondering if that's what we mean by assessment measures. But we also have some functional measures and some quality of life measures. It depends where we are, and therapeutic alliance. I think that we touched on it a little bit earlier as well. When we were really looking at the measures, we had focus groups with clinical folks, with researchers, with the organization in and of itself, but with clients and patients as well, both inpatient and outpatient, to really understand what was meaningful and impactful to them. So a lot of these conversations and stuff for Homewood also came from, other organizations saying, like, what's your success rate? Well, what do you mean by success rate, right? So we had to also have that understanding of what do we mean by that. But we wanted to know from the individuals themselves, what is success to you? And we brought in some of those. So actually one key measure that we brought in for that was hopefulness. That was a major thing that came up from every interaction with patients or clients. They wanted to have hope back. And so now we measure hope. And it is often, and one of the biggest ones that we talk about when we're interacting with clients. It's come up from other groups when I've had these conversations or been at conferences as feedback from patients and clients as well, that's a key measure. So that's kind of an overly large answer to that question, but I think we were trying to really make sure that we had a kind of more fulsome look at the individuals it's not just about symptom improvement.
That's very helpful. This is a good segue into the next question. Mentioned about measuring hope, but what are the standardized screening assessments that you use today, and have these changed, adding or removing specific assessments as part of the evolution?
So we use, like I said, symptom measures around anxiety and depression, so the PHQ and the GAD-7, they're pretty commonly used. We had many opinions about what depression measure specifically, depending on who you asked. Everybody had their own version of that. But we also wanted to look at measures that were available and could be accessed if you were no longer with Homewood, right? And so that if somebody wanted to continue using a measure or go back to their family, doctor, community support, they could also gain access to that. With that said, then yes, we also have adapted and changed things as we've gone. So we started with, during this whole journey, every time we looked at a new stage in our process, we really looked at what are the measures, how does this look? And then the most recent assessment battery that we have in the inpatient, we had a different assessment battery in a trauma program that we had and in the addiction medicine program. So we really looked at those to see what made sense, where could we standardize across the way, and then what was that kind of core battery that we would want to ask everybody that came into our voluntary programs, and then what would be those additional measures that might be helpful to have for subpopulations. And then again, I know that we are moving to a more integrated use of this information because now we have clinicians, psychiatrists, and other IDT staff, interdisciplinary team members, that will say, do you have a measure for? And so we bring those and make those available where those don't have to necessarily be even repeatedly used and all of those, but it can really give some baseline information or be used as a check-in as needed as well.
I think that last point is a really good one, and I, having worked with Shannon for the last 5 years, I've seen it firsthand. There are a lot of ideas, requests, suggestions for new types of measures that are much more specific in nature, that in the majority of cases are actually coming from the clinicians. And I think Homewood's done a really great job encouraging clinicians to put up their hand and ask, because it's a great way to get buy-in. If clinicians in their practice identify a specific tool or group of tools that would be impactful, we absolutely want to make those assessments available. It allows them to feel heard, and it makes it more impactful. So listening to clinicians is certainly important, not just in the beginning, but also once you've gotten started. Next question. How are you communicating to leadership the return on investment that measurement-based care brings to the organization?
So I think that I would take a step back, and by us having measurement-based care in practice, we've actually been able to just measure some level of return on investment that we wouldn't have previously been able to measure, right? So if we didn't have any of these measures at all, how could you put a true ROI against it? So for some of our programs, we can give that to a dollar amount. Some of them we are working on what could that look like. We are also looking at really the literature and understanding and even trialing out with our data without sharing it externally yet. How would you measure a ROI for this program or this service or this patient population? What could that look like? So in some programs in our outpatient world around ESAP, employee assistance programs, we actually can ask about very work-specific questions. But in our inpatient world, that doesn't really align. Mm-hmm. So it's not as direct of a measure to give us a dollar value. But we do know that certain levels of symptom dysfunction or symptom severity leads to certain amount, like the literature starting to come out to say, like, if you have severe depression, then you're likely missing work X amount of time or missing or not as present at work, things like that. So then we can use some of those values to convert into ROIs. So I wouldn't necessarily say we're communicating back measurement-based, the return on investment from measurement-based care, but it's actually allowing us to have the conversation about return on investment in and of itself.
Thank you. A couple other really interesting ones here. A question from Erica on, can you tell us about the onboarding process to get users onto Greenspace and the resources you specifically devote to that?
So we have right now admins within each of our key service offerings. So within each kind of location, or if there's an outpatient set of programs, who we have intake processes to have them onboarded is an awful word for that, engaged in one of the programs and start a program. So we've actually just integrated their onboarding onto Greenspace into each of those processes. So if somebody was being admitted into inpatient facility, then in that moment they are added into Greenspace. If they are being going through intake for one of our outpatient programs, the intake would add them in. This is a piece where I think there was another question. EMR, is your electronic medical record. So this is a part where this will all become automated over the next couple of months for us. Some sites this is already working, but we are rolling it out as we speak so that it doesn't even require a person to add it in. But we do have admins who were already doing that process, and it became part of their tasks. And then we have my team is there to be available and support, and there's really myself and one other person on the team who can support when these teams need it, but we're not in the everyday operations.
That's very helpful. A couple others that I think are particularly interesting, especially the work that you do at Homewood. Is there any follow-up data gathered after discharge to gather information around relapse and see the longevity of different treatment modalities?
So this is something we are looking to launch more formally, or in a standardized way across all of our programs, but in some of our programs we are already doing this. So I think I mentioned early on we started out right away having a 1-year follow-up time period where we checked in 4 different times. And so that has not been, we've continued to do that within that one pilot program and brought it into a couple of them, but now that will also be something that we start to do across all of our programs, and that really does allow you to understand what impact or how are the treatment gains maintained. Because if you have all the supports and you have everything you need, yes, most people will get better, and that makes sense. But once you're back in your everyday lifestyles, were you able to achieve those and maintain them? And so we have been able to see up to a year after folks have left that things around relapse and drastic improvements were still maintained around reduced use or drinking and the amount of or full absenteeism around those things specifically.
And do you have plans to be able to be proactive around that? So if you identify somebody who maybe has relapsed, rather than just waiting for them to seek out additional services, do you think there's an opportunity to be more proactive?
Yeah, so now that we have the system in place in which to collect this, one of the conversations, and we will probably start with getting some feedback from the kind of community group that we're working with on how to really bring practices around measurement-based care into play, are what does that engagement look like? And so everybody's program or organization will have a probably a different view of that re-engagement into the system. But I think we want to make sure that we are able to identify flags or triggers that would say, you know, this person is on a path that maybe we want to reach out and say, you like, here are some options, or just flag it, because sometimes it's also just about the awareness.
That's very helpful. Another interesting question. Where are we here? I've lost it. Do you think the industry will change toward requiring measurement-based care in the future? I'd love to hear your thoughts. I have a view on that as well.
I think so, and I think in a way that we should. You don't go to your family doctor or a kind of traditional medical system and not have standard measures in place. And so why is our industry different? And I think you can't argue anymore that the research is out there that using measurement-based care in and of itself will lead to better outcomes for individuals. And then the more it's integrated and part of the conversation and part of their clinical practice, the better the outcomes. So why in a system right now where we don't have the resources, people or financial, to meet the needs of Canadians' mental health and substance use, or probably health in general, why would we not be looking at tools to really maximize the benefits so that we're getting people at the right stages of care when they need them?
Yeah, look, I agree with the answer. I think you've taken a very ground up logical approach to answering that question, and it'd be very hard to argue with that. Maybe what I can share from a 10,000 foot view is, I mentioned this at the start, but we've been exclusively focused on bringing measurement-based care from research into practice for the last 7 years. 7 years ago when we started, for most organizations we spoke to, we had to explain what measurement-based care was, or at least our definition of it, why it was important and impactful, and then third, if they believed those first two things, why they should consider Greenspace as a partner to help implement. That's changed dramatically. Almost never do we now have to explain what is measurement-based care or why is it impactful. And I think that's important because across the board, organizations recognize the impact of practicing with measurement-based care. It doesn't mean everybody's ready yet, and that's okay. But not just in our view, but with different partners we work with, across North America, more than ever, there seems to be clear conviction that at some stage, everybody will practice using measurement-based care. We don't yet know whether that's going to be 18 months from now or 5 years from now, but for people who've been doing this a long time, that is very much the prevailing view, which I'm really excited about. I think we have time probably for one more quick question. Maybe Shannon will answer it in 60 seconds or less. Have you used measurement-based care for groups before, and can you speak to that?
We do. So we have, like I mentioned earlier, each of our services or programs were kind of offered, how do you see this working within your kind of service or program? And so we have many programs within the inpatient where they actually do a group, especially during that first week for intake. Everybody can kind of come in, the patient or the client is sitting in the room, there's a therapist present, so that if there's any concerns, they can ask questions. If they're triggered by anything in there, there's somebody right away to help support them. They can explain why they're there. Then we're able to move where we might continue with groups at each of the time points. Or the individual might be like, no, I'm comfortable with this. I know how this is being used. It's part of the conversation. I'm just going to complete this on my own on the week that I'm told to do it. So we've been able to use that in a few different ways. And really, everybody comes in, you explain, today we're doing our assessments, and somebody could be doing their first one and somebody could be doing their discharge one. This is why we're doing it again. We're going to do them right now. You can just stay in this space and answer. If you have any questions, we're here, and then we'll talk about the results either in that moment if somebody is free and that works, or you'll have that conversation with your team or your key prime therapist or clinician when needed.
Thank you. That brings us almost to the end of our time for today. So a big thank you to everybody who attended today's session. I'd also like to take a moment to thank Shannon for being here with us today and the work that you do every day at Homewood to improve the lives of patients. Homewood is clearly a standout organization that's a leader in the movement towards high quality, ever-improving evidence-based mental health services, and we're thankful to be your partner. We've been blown away, honestly, at Greenspace by the continued implementation of measurement-based care, and are excited by the momentum that's clearly continuing to grow. I spoke about it to some degree, and it's accelerating across organizations of all sizes. If anyone is interested in learning more about Greenspace and how we support the implementation of measurement-based care, please feel free to reach out anytime. We're happy to talk about it. And as well, Greenspace will continue to host measurement-based care educational sessions like these in the future. So please stay tuned for our next session, and we hope to see you all there. So thank you very much. I hope everybody has a great rest of the day.